Okay, then we'll give it a go. Good morning, everybody. I'll just briefly introduce Professor Nalakamendis, because although he doesn't need introduction to most of us, but the current trainees probably don't know him much. So I think it's my responsibility to briefly introduce Professor Nalakamendis today. So Professor Nalakamendis has graduated from the University of Colombo in 1971. He has joined the Department of Psychiatry, Colombo University, 1974, and appointed the chair in 1988. And he got his membership of the Royal College of Psychiatrists in 1978, the fellowship in 1987, when he got his training in the UK, and he continued his professional development at the Harvard Medical School, the UCL London, Wellington Medical School in New Zealand, and the Centre for Addiction and Mental Health in Toronto, Canada. He was appointed as a senior professor of psychiatry in 1997 in the University of Colombo and retired as the emeritus professor of psychiatry in 2011. And he has given leadership to the curriculum reform since 1994 in the University of Colombo, where he was instrumental in extending the clinical appointment in psychiatry for two months, and also making psychiatry as a separate subject at the final MBBS exam. And one of his major achievements is the establishment of the National Council of Mental Health in Burala in 1982, which is known as the Sahane Resource and Information Center, which later initiated a number of community-based activities, establishment of the Community Mental Health Center project, the first Community Mental Health Center project in Colombo in 1983, which also was responsible for the commemoration of the World Mental Health Day for the first time in Sri Lanka in the early 1990s, and also the initiation of the MO Mental Health Program in association with the Ministry of Health in 1998. And I can jolly well remember as a very junior registrar, as in 2002, Professor Nalakamendis convened the first international meeting on community mental health in Sri Lanka in 2002, which was a great success, where he managed to invite quite a lot of eminent, world-renowned psychiatrists from all over the world. And he was the founder president of the South Asian Forum on Mental Health. He was a founder member of the World Association for Psychosocial Rehabilitation, and was a temporary consultant to the WHO Geneva and Delhi, and represented Sri Lanka at the World Health Assembly in 1999. He has been an author of more than 100 scientific publications, presentations, and books on mental health and community psychiatry, and also drug abuse. At present, Professor Nalakamendis is engaged in compiling a book on post-colonial development of mental health services in Sri Lanka. I think Professor Nalakamendis may be the best person to talk about this subject today. He's going to talk about to us on the improvement of mental health in Sri Lanka and the challenges faced by the profession. So without further ado, over to you, sir. Thank you very much for agreeing and accepting our humble invitation to do a presentation for our trainees. I think all the trainees will be really very grateful to you for doing this, and they will really benefit from your presentation. Thank you very much.
Right. Thank you very much, Gihan, for this very long and grandeur presentation. I don't know whether I deserve all that. But I'm very happy to be with you this morning, just to share some of these thoughts and the trends in developments in mental health years to come, which I suppose would be your integrated to your practice as you go on. Maybe what I'm going to say might not be very useful for you for the exam point of view or practice point of view at the moment, but I'm sure in time to come, these will have to be integrated into your clinical practice for you to be a better clinician and a better leader in Sri Lanka or elsewhere. So shall I, we will start with the slides now.
Share screen. Can you share the screen?
Yeah. Can I share the screen with you? Okay. Recording.
Share screen. Share screen.
Share screen here, green.
There is your presentation.
Yeah, this one, yeah. Can you see the slides now, Sumudu?
Yes, sir, we can see.
Yeah. So good morning, everybody. This is from Diatalava, what used to be called Happy Valley. This is a view from our window, actually. Yeah, right. So let's go to the slides, and this is some beautiful waterfall, Burala. Just we can see from our house actually far away, especially on rainy days. Even now I can see it actually. It's far away, coming down from Norelia. I really wanted to talk about the modern mental health issues, maybe not so relevant at the moment, but as I said earlier, years to come. Normally, generally modern mental health evolved in the West based on ideas, knowledge, values, and practices in those parts of the world at scientific, political, and practitioner levels. Broad way, some of these things we can divide into the three phases in the development of modern mental health services in the world, actually. The beginning of the asylum era was 1840 to 1940, about 100 years, where the people are incarcerated in the asylums. Then came the 1930s and 40s, where the early treatment of mental illness was initiated through the mental hospitals and general hospitals and the community. That's the beginning of the community mental health era, 1940s to 1980s. Then came the 1980s onwards up to now, and continuing what's called the beginning of the public mental health movement and the consolidation of community care. I'm not going to go into any of these details because each of these is a lecture on its own right. I will just skim through the surface and highlight some of these issues so that those who are interested will start reading about it, because there are plenty of reading material are available in this matter. So my topic is going to be improving mental health of individuals, communities, and population. Now that itself is interesting, because when we talk about the doctors, the clinicians, we talk about the individual patients. But today the mental health is spoken of individuals, communities, and populations. So that itself is an added thing which I will go into later on. And the whole emerging concept of population mental health, which is beyond the community mental health movement. So community mental health movement is really the modern term that is used everywhere, which started in the 1940s and accelerated in the 50s and 60s, which came to this country about 65 and then went on. But now it's being complemented or replaced to a certain extent by this concept called population mental health. Why did this happen? For the simple reason that 21st century has come up with plenty of new needs of persons, families, communities, and populations, not only the individuals. And the two major aims of the new idea is the lowering of the burden of mental health or mental ill health, and the enhancement of mental well-being. Now, these may be appearing to you as just words or cliches, but all these things have a very big meaning, even in our society, and years to come everywhere. And these are important for us to recognize now, although they appear to be very theoretical at the moment, which are alien and divorced from our day-to-day practice. And we thought through when we were students, actually, in the 1970s, this is how we thought, because we were brought up in a very, very biomedical model from the medical school or from the school onwards. But we realized as we went on, there are other issues that are relevant to our practice. The three issues are the health promotion, illness prevention, and the management of ill health, which I will come to. And the last need is it's an integrated system of care, not only the psychiatric services, not only the mental health services, not only the health services, but a wider spectrum, integrated cost-effective approach while respecting human rights, which has come in a very big way to mental health, which is very distinct from the present system, which is disease-oriented. We are always interested in the assessment and diagnosis, schizophrenia, mood disorders, obsessional illness, various things. And we are generally individual-focused, specialist managed, and this system has been going on from the 1940s. But today, what has happened is we have got more and more interested in the issues of health, wider issues, which has been followed by biomedicine or the medical approach in the 1940s and the 50s, but the re-emerging. So I'm trying to focus attention. My aim is to sensitize the trainees who are sharing this discussion to these evolving trends. What are these issues that are developing in the world? And then point out how these developments could be integrated in Sri Lanka. And I'll give you some examples as to how this happened in the past. The term mental health, when I use here, it includes both mental health and mental ill health. I don't want to use the term mental disease or mental disorder, which are traditionally very old names, but normally people would like to talk about mental ill health today or mental health. And the improvement of mental health, when I talk about improvement, like to refer to enhancement of well-being, which is another new term, which is, although it's a newly articulated or discussed and expressed very well today, it's a very old term. More than 150 years, people started asking about the well-being. The reduction of burden is a new one, which came in the 1980s with the global burden of disease, is a new one, which I will talk to you later on. So why did this happen? Why did all this transformation take place? Because of the influence of the new developments in the field of medicine as a whole, and the whole world around us. Can you hear me? Can you hear me?
Yes, sir, we can hear you. Yeah.
All right. So the first point is we have a much bigger understanding of the relationship between health and well-being, which I'm not going to go into because that itself is a talk on its own right. But we have to understand that the health, we always decided to divide these two into health and disease earlier, even the World Health Definition, 1946. But the 1984 definition is very different from the 1948 definition. Now they talk about the well-being model of ill health. It's a sense of being, how we feel about ourselves, about the world around us, our behavior, and then our fulfillment and our purpose. And also seen as a resource or capacity to realize our potential. The mental disease is no more mental disorder seen as only schizophrenia or illness or bipolar disorder. It's a whole range of activities: mental illness, psychosocial distress, poor well-being, developmental disorders, behavior disorders, neuropsychiatric disorders. If you really look at the ICD-11, in the latest one, you see all these things. So mental illness is much broader than what it used to be. And there's a huge connection between neurochemistry, behavior, and neuroplasticity, which I am again not going to go into. Although we thought earlier there was different components: chemistry, behavior, neuroplasticity, molecular biology. But now we realize all these things are related. And well-being includes not only the individual. When we talk about the well-being, we talk about the individual, community, population. In fact, if you talk about the Sri Lankan Constitution, it starts by saying well-being of the nation. What it means, I don't know what they meant, the Constitution makers. But even if you look at the Sustainable Development Goals, it's the well-being again. So these are all related issues, and neurochemistry, behavior, neuroplasticity, mental health issues. Then the measurement of impact has changed. Now the global burden of disease has taken the center stage compared to the morbidity rates of epidemiology long years ago. Now it's a global disease burden, which was started in 1982 by Chris Murray. And the importance of mental health in life has become very, very important. Earlier, when we talk about mental health, we talk about the mental disease, but we don't talk about disease alone. We talk about the entire spectrum of mental health, essentially how we feel about ourselves. And if we are doing very well in our lives, enhanced well-being, we resist becoming an ill person, which is an indirect relationship, but which I will go to. And now we know that we can enhance well-being in people. We can prevent mental ill health, and we can manage the mental illnesses much better than what we used to by a holistic approach. Then, of course, issues of human rights. Earlier, we thought human rights was just a marginal to it. But now we feel the centrality. It's a very pivotal. Mental health will affect human rights will impact the mental health. Similarly, close relationship between the physical illness, mental illness. We all know people with mental illnesses, especially serious mental illnesses, die 20 years earlier than the other people. So there's a very good big relationship between the two. About 40% of the people who are suffering from a mental illness also will suffer from a physical illness. Social determinants, a thing that came up in the 1970s and 80s, and ACE, or adverse childhood experiences, are central to mental health. We know education, income, poverty, housing, all these things will contribute to the development of negative mental health. And finally, we know the stakeholders are not only psychiatrists, not only other mental health professionals, but it's the whole society is responsible for the mental health recovery, quality of care. And today, when we talk about mental health, we talk about the widening gap between the needs and the services, whether it's in access, human rights, responsibility, who is responsible for mental illnesses or mental health, accountability, who is accountable, ourselves, family, society, government. You know, these questions are being asked, and these are being discussed even here in Sri Lanka. Quality of life, quality of care, quality of services, aims of care, management, mental health, and the creating new knowledge. Now, all these seems to be far away from you because they're not available in the textbooks. We study the definition of quality of life or quality of care and vomit it out at the exam. But I am talking about a much bigger concept, much broader concept with a bird's eye view, because these are becoming important. Even now, people will ask questions from us, even our patients. When you write a letter overseas, they will ask questions. What is the training? What is the quality of care? What are the guidelines? Because people would like to have the best possible services that are available in the world. And with that, I go to the next, my substantive talk about the morbidity or the global burden of disease. We know about 25% or 20% of the people, global burden is due to mental illnesses, measured on a disability adjusted life years, or DALY, based on the years lost due to disability, years lived with a disability actually. See, schizophrenia, if you get at the age of 25, or obsessional illness at the age of 18, you're going to live till about 65, you are living about another 40, 50, 60 years with disability. And then you lose life, years lost, years lived with, years lost, years life lost, YLL. And if you add that, you get the disability adjusted life years, and then that is how you measure the neuropsychiatric disorders, which involve all the disorders I mentioned earlier. And others are all way down. So that is what we are going to put down, try and reduce the global burden of disease. The second concept that we have is the enhanced well-being of population. Now, enhanced well-being is something that we are striving or we are aspiring to get at, all of us. But we don't think in those terms actually today. But increasingly people start asking those questions. More people having enhanced well-being means more people will resist getting an illness. So I'm not going to go into any of these details any further because it's all available in any textbook, or you go to internet on well-being, books and books have been written. Essentially, all we know is well-being is essential for life. Poor well-being, you are vulnerable towards mental and physical illnesses. High well-being, you are resisting illnesses, including schizophrenia, which I will probably I will not have time to go to, but there are lots of studies which says that it can be prevented. And then there are ways of enhancing well-being. And that is part and parcel of health promotion, which is, although they seem to be very alien at the moment, many people don't realize that we are practicing it all the time on ourselves or in the community through various programs. Yes. I have a problem. It's not moving slides. Hello? Can you hear me?
Yeah, we can hear you. Sumudu, I think there's a problem of the slides not moving.
Your slide is not moving, probably.
Sumudu, is there any problem?
Yes, sir. Sir,
Is it from
yeah,
my
you
end?
can press this. Yes, sir. Yeah. You have to press this arrow, sir. Left side corner.
Yeah. This
Yes.
arrow?
Done. Yes, yes.
All right. Thank you. Thank you. Yeah. So this is a sort of a representation. Again, it looks very theoretical, but don't be worried about it. Basically, these are the three components that we are talking about. Mental health promotion essentially means that we empower people, support them so that they have to be resilient and competent to resist any illness, which you might not understand it now, but I will try to explain a little later. But of course, I'm just giving a bird's eye view of it, but you will have to do some more reading and try to appreciate the fact that these are possible things. Then the area of prevention, again, universal, selective, and indicated prevention. Essentially, what is meant by this is that a certain percentage of illnesses, mental illnesses or physical illnesses can be prevented. It's like saying the other day, someone said, you can keep on doing bypasses, you can go on doing stents. Does that mean that the heart problems in the community will lower? It will not happen. We have to do various other preventive measures, nutritional measures, high blood pressure, family, and that kind of thing. Then, of course, we have to have the treatment issues and the maintenance and so forth, which I'm not going to go into, because that is what we are very familiar with all the time. All the time we are assessing and trying to treat people. But we tend to ignore the other areas. The third area, the pillar on which the triangle we rest is, first is the burden. The second thing is the enhancement. The third thing, the population. We are familiar with focusing on the individual. But increasingly, people realize that even if you take 200 families in the community, we can treat every single patient. But there may be so many patients who are not coming to see us, who come to see us, but who stop halfway through. So therefore, if you really look at a community, a certain population, there'll be very varying outcomes. That's what it means by population health, which is becoming very important compared to the individual health. Global burden of disease strives to minimize these inequalities so that people have closer and closer relationships, and the closer inequities will be reduced. And that is done by the non-clinical interventions and activities intended to improve mental health outcomes in the community. Now, these seem to be very, very theoretical kind of statements that I make. I can assure you they are not. As you start practicing, as you start looking at the big picture, you will start appreciating what I mean. So I'm merely introducing the concept of population mental health. No way I'm going to discuss in detail, because that itself is 1 hour talk on population mental health. Now, this is a slide that I had taken from the Canadian journal. Say it's, if you take 100 people, we see the last 20, the low part, the acute end of the triangle, lower end of the triangle, about 20% of the people who are ill, who come to the clinic. But the 80% of the people won't come to see us. Some of these people have preventable conditions which could be easily, if intervened, they will not come to this 20%. Then another large group of people, if their health is promoted or enhanced, or well-being is enhanced, they will not get into this other group. So ultimately what happens is this whole group, if you try to enhance the well-being and prevent illnesses, this number can be reduced in certain groups of people in one population. So that is what it is means. And this came up from the earlier studies called Michael Marmot, who studied the social determinants, what he said was, why is it that in a community, if there are 100 people, but certain people get alcohol dependence, certain people get depression, certain other people get something else. And he proved with his evidence that it's because of the education, housing, poverty, healthcare, then various other income discrepancies, then human rights issues and injustices and so forth. Those things will impact on the individual to lower their capability of promoting or preventing illnesses by way of their behavior, lifestyle behavior, alcoholism, suicidal behavior, dangerous behavior, nutritional, all that kind of thing. So if you really look at the population macro picture, these things become absolutely important in our care of our population health. Another area which we have really neglected was what they call the psychosocial distress. There was a time in the 1980s and 90s when we were studying, when we were younger, we only talked about the mental diseases or mental illnesses. The rest we were not interested. They were adjustment reactions or reactive depression or something to do with the family or stress or whatever it is. But increasingly now people realize, in fact, the psychosocial distress causes more of global burden of disease than diseases themselves. So the psychosocial distress is really a response to stress in psychological or social terms, ending up with enormous amounts of problem, including suicides. So psychosocial distress is a very important concept. Managing those with ill health, I'm using really the more trendy terms. I'm not saying treatment or disease. Treatment or disease is essentially a very old concept. Now we manage a person who has an ill health problem. Because disease, he doesn't have only schizophrenia or he doesn't have only bipolar illness, he has other problems. He has educational issue, he has a family issue, marital issue, children's issue. He has a personality problem. So therefore, we are talking about the management of ill health, which we measure by the outcome of this person. To what extent has he improved come out of those situations? And more people recovering, having better health and physical and mental health, good experiences. That is what we want. Better quality life, less harm and less stigma. And then that is through designing a very good program of management, evaluation, outcome-oriented services, not only of the individual person, but the family and the neighborhood and the surroundings in a continuing kind of fashion. That is what is called the managing those with ill health. Now, those people who are listening to me, who are doing their hospital work, will wonder, what is this man talking about? Can we do all these things? Sure, I understand these things. I also have been a person like you. But as you grow older, when you become responsible, more and more responsible, you realize that you have to address those issues. And then you get more resources. When you develop an organization, you get the support of everybody else and start realizing these kinds of things. And in fact, if you get ill, this is what you are looking at actually. We realize that when we get ill, we want all these things that we talk about. But when the patient is on the other side of the table, all we want is a diagnosis, ICD or a DSM diagnosis. What is the drug he gives, and you give the drugs, whether he takes it or not is not our responsibility. So that is the point that I'm trying to emphasize. Very often when you talk about, especially the senior psychiatrists will talk about, what are you talking about prevention? You can't prevent, can you prevent schizophrenia? Can you prevent mood disorders? Can you prevent obsessional illness? There may be some truth in what they are talking about, but they are also not talking about many areas where you can prevent mental ill health. There are lots of studies, especially ACE, adverse childhood experiences in children. Those children who have had ACE, there's a higher tendency to develop carcinoma of the lung, high blood pressure, coronary heart disease. There's a huge amount of new research that's coming out in all these areas where primary prevention is possible. And if not, there's secondary and tertiary prevention, which I'm not going to go into. So prevention has come to stay with us And we as psychiatrists or mental health professionals will have to think of that. Human rights. Human rights seems to be a very much a cliche, and people say it's a very, upper class kind of a thing, lawyers and the legal profession, moralists will talk about. Certainly not. If you really talk about the primary first generation of human rights, we are talk about you are not harming anybody, individual, and people are all equal, that kind of stuff. Then you talk about the second generation of human rights, equality business of dividing resources among equally to people. Or the third generation of human rights, we are talking about the rights of special groups of people, religious rights, cultural rights, and so forth, or right to have health. So really, mental health and human rights is very close. I myself was rather cynical about it in the late 1990s when we talked about in the WHO how important it is, the mental health. We're coming from a third world country, coming from a very biomedical setting. I didn't understand what they were talking about. But when we started learning about it, when we started hearing these kinds of things from ordinary people who are coming to see us, I realized they have a meaning in these societies. Although at the political level, they try to neglect it and marginalize it and say, no, that's unimportant. It's important only in the West or something like that. I feel that human rights is very, very important, especially participating, joint decision making about an issue, quality of care, focusing on the least marginalized, most marginalized groups, and the rights of access to various possibilities. I was talking to Gihan in the morning about vaccines, how accessible. The most wanted people have to access to that vaccine. Vaccine is something that is given from one country to another country. Can you divide among their friends or powerful people? No, it has to be given to the people who have the vulnerability, most amount of vulnerability, so as to they deserve it. Now, those are the issues of human rights, which impinges on centrally more as a core in mental health issues. Integrated people-centered health services. Again, we work in different departments. We say we are isolated. You refer a patient to another person. Very often they are fragmented. We don't want to share our experiences. Health within health itself, public health on one side, the curative care on the other side. Within the curative care, there are a huge amount of segmentation, and primary care, secondary care, tertiary care. So really, when you come to that, one patient is pushed from one place to another. We are talking about an integrated people-centered healthcare, because health is for the people, not for us. So therefore, increasingly people start talking about integrated healthcare. So what do all these things mean? You see, what happened was, all these years from the 1940s onwards, psychiatrists thought we were the owners of mental health. Psychiatry, no one else should come and interfere because we are the experts. But increasingly people realize the experts have not been able to deliver because mental illness goes up and up and up. Global burden is going up and up and up. So after that, what happens is there are a large number of other people who came out, especially from the public health, and said, no, we have to take it out from the it's hidden within the psychiatric profession or in the mental health or the mental asylum. We'll take it away from the professional, administrative, and the political isolation of psychiatry to the broader human agenda or national agenda. And that is through public health approach. That is the approach that's coming up now. And that is what I'm going to talk about. Public health approach essentially is a new term which is established in the 1980s and 90s. Essentially involves three aspects: the promotion aspect of it, as I said, to resist ill health. Prevention aspect is essentially to reduce the risk of persons. Management aspect is essentially to reduce the impact. Now, there's an interesting statement which says mental health care is vital to all of us. Sometimes, one of us will get ill. definitely, sometime of our lives, because there is a chance of 1 in 5 or 1 in 3 or 1 in 2 developing some mental illness during the lifetime. So mental health care is essential sometimes. But public mental health is vital to all of us, all the time, because we need peace, we need the human rights, we need good water, we need good air, we need good environment, we don't need violence, you need all. So public mental health is that's what we are talking about, and we need all the time. And that is something very important that I like to stress. And this is a very important slide. Over the last 15, 20 years, there's a large amount of material that has come up on public mental health by the World Health Organization, by the government of United Kingdom, by the Faculty of Public Health from the College of Physicians in London. Large amount of material on the area that I talked to you about. There's especially a good book that has come out called Mental Capital and Wellbeing, come out from the UK government. Beautiful book about the importance of mental well-being and mental health and relationship to the health and the trajectory in life. Whatever you do in life is associated with your mental well-being. So please refer to all these items are available in the internet. You can go to the internet and download all these articles. Now this is a very important thing. These are all College of Psychiatrists. Nothing, you are all aspiring to be part of the Royal College of Psychiatrists. And the Royal College of Psychiatrists accepted the public health. The need to translate this new evidence to policies and practices have been emphasized by many, including the Royal College of Psychiatrists. Not only that, World Health Organization, World Bank, World Psychiatric Association, you look at the whole World Federation of Mental Health, and all leading countries, they have accepted the public mental health approach. Although they're trying to translate that into reality in stages, it's very difficult because we have to have complete transformation of way we handle, way we view the things. Because especially the senior psychiatrists will laugh at these things. They're very cynical and say, we can't change the world, we can't do this, we can't do that, we can't do that. But there is a need to do that. There's a need to do that. And if you really start reading these things, looking at the achievements they have made, you realize that these things, there is a place in the society. Now, what about Sri Lanka? All this time you would have thought that I was talking about, unreal theoretical things which are possible. They're not. These elements have already been introduced in Sri Lanka. I will go into some of these things, maybe very early elements of it, but we have not got them institutionalized so that the policies are developed along these times. Individuals come out with some ideas and try to bring about a little change in the local setting, but not in the whole country. In the whole country, everybody today even is talking about community care. That means a general hospital psychiatric unit and some outpatient clinics, maybe outreach clinic, maybe some community psychiatric workers or community support workers or whoever it is. But that's a very primitive, very early stage of even community psychiatry. But now people have gone beyond community psychiatry. If you look at the American Academy of Postgraduate Education, for them, part of the training is now public mental health. Australia is changing. So people are changing, depending on the developments in the rest of the world. And in fact, if you really look at the Sustainable Development Goals, which was 2018, mental well-being is a goal. Prevention of alcohol is a goal. For the first time, the people in the mental health profession fought with the World Health Organization, with the World Bank and the UN, and got these things integrated into the world system. Essentially, that means that we get more money and more resources. That means we have more services. So it's a reality even in Sri Lanka. Can we implement these things? Yes, we can. If we can implement, we have to reform the prevailing clinical services. and introduce public mental health approaches, which we have already done in small ways, which I'm going to describe now. Now, these have been going parallel, side by side, in a small way with the main psychiatric services. We try to bring out psychiatry from the mental asylum, Angoda, to the general hospital and to the community, bringing out mental health out of isolation from the public domain. Those days, people will not touch psychiatry because they are part and parcel of the psychiatric system. So we have started doing that. We'll show it later. Promotion of mental health, we have integrated in small ways with the general health integration programs. Not in a big way, but very small mental health promotion programs we have come up in Sri Lanka. Prevention of suicide is there, about the insecticide, pesticides, you know that story. Child abuse, in the 1990s, Mrs. Chandrika Kumaratunga introduced the Child Protection Authority, then brought in elderly, children, social welfare, various kinds of preventive programs for which people are appointed, and they are now placed in divisional secretaries. And there's a central body which are aimed at what we call the psychosocial or prevention, early childhood, rights of children, various things like that. They are all part and parcel of promotion and prevention. Meeting of comprehensive services. Many people, we talked about Angoda earlier, brought in about community support workers, community psychiatric nurses to go and give the depot injections. Somehow that we are trying to introduce psychosocial counseling for these people to fulfill the needs of the patients. And integrate the coordinated. I know in Ampari, maybe in Trincomalee, maybe in certain Kandy, maybe in other areas, they try to integrate, work with the schools, work with the divisional secretariats so as to have a seamless, coordinated kind of a service to the people. Population health through community support workers, especially in the northern area. I know people have been trying to work with populations. When Dr. Ganeshan was there in Badikalo area, psychosocial health, community-oriented things, they started these programs. But unfortunately, we couldn't really institutionalize them. Psychosocial trauma with the war in the north, Dr. Sivayoham, and before that, various other people have tried to introduce trauma-related or domestic violence-related issues. And of course, human rights legislation, we at Sahania, you will be surprised to hear in 2001, rights-based approach legislation, and we gave to the Ministry of Health. And I don't know what happened to that after that. But these are very important developments which came from non-psychiatrists, but in the major stream of psychiatry. Now, this is essentially Sri Lanka, all these things. Now, this is an interesting book which is written by Mental Health and Wellbeing in Sri Lanka. Suman Fernando is a psychiatrist. He's a local psychiatrist. He's about 80s now. He's in England. He used to be in Cambridge, and I know him quite well. And he came here with Chaminda Virakkodi, looked at mental health and well-being in Sri Lanka. And this is a very familiar site. And this is now, private sector firms are trying to take in some of these issues, mindfulness and yoga exercises and various things, and improve the Can you hear me?
Yes, sir, we can hear. Yeah.
Right. Well-being, what I'm trying to tell you is even ordinary people in the community are absorbing these concepts and trying to practice them because they feel it's important for their lives. This Sahania 1982, I mean, this is long years ago, 40 years ago. Talked about that time, we talked about 1 in 80. And in fact, we used it, if we really use the term, we didn't even use the mental health. That time, the term was mental problem. We didn't really want to call it mental disease because the moment you call mental disease, mental illness, there is going to be a stigma. It's interesting, this was planned in 1982, these buildings. You see, we had a very good architect, and the architect, we had to now try to find out how does, what is the concept of mental health at that time. So we developed ideas of beautiful surroundings by the golf course, greenery, and various things. I remember medical students coming there for the first time, they saw the golf course, and that was part of well-being of these students. And even today, they are big consultants. They talk about their experiences. For the first time, they felt different from an asylum or a general hospital, ward 59. And these are some of the things that we did in the 1980s, awareness activities. This is also part of public mental health, actually. Getting people into your confidence and showing them, in fact, we are like you, all of you. I'll just stray a little bit outside just to show you, tell you that the asylum, now it's called the Independence Arcade, was the mental hospital, Cinnamon Asylum, Cinnamon Gardens Asylum at that time, which was built in about 1890, which was there till about 1925. Now, recently it was redone, and now it's called the Arcade. It's all mental asylum, and I went there a number of times when they were doing it, and they were not prepared to identify themselves with an asylum. The person who was in charge was a brigadier, and there was a colonel, then there was a major. They said, when I went and said, please tell me, Mr. Gotabaya Rajapaksa, at that time, he was a defense secretary, to get this, connection and rename it. They said, no, this is nothing to do with the mental asylum. This is part and parcel like an arcade in Singapore. All three of them had their relations, had mental illnesses. And they came to me, actually. All three of their wives or children or who it is. And then they realized the importance, and they convinced Gotabaya at that time to put a plaque there to say how, and I wrote that plaque. The entire plaque is there still at the entrance to the asylum. What I'm trying to tell you was how to get these things out to the public domain, which I'll show you later on. These are some of the things that Gihan talked about the conference. These are proceedings of that. We did research with the World Bank, and which led to the establishment of the MOH program. There we worked with Dr. Sarojay Singh at that time, was a physician. Then we worked with Rajita Vikram Singh, who was a public health man. We worked with Amala De Silva, who was an economist. Ms. Dr. Tilak Munasinghe was a health education person. We brought in a large number of people from outside to get this mental health concept out. In fact, the term MOMH, Medical Officer of Mental Health, was proposed by Dr. Tilak Munasinghe, not by me. They want to bring up the health issue as they went on. Now, as this is 1990s, we talked about improving mental health. We produce various kinds of documents to get people involved in mental health. Caregivers Association, which was started about 1985. And this is fascinating experience. This is the Director General of Mental Health of the WHO Mental Health Director. These are the three presidents Gihan was talking about, Kendall, Sims, and Shooter. Kendall is dead now. And these are very important person, Professor Neki, first professor of psychiatry in India, All India Institute of Medical Sciences. And this is Dr. Barma. Dr. Wig. And this is an interesting man. He's a president of the World Psychiatric Association as Afzal Javid. He was a good friend of mine. And this is the person who is in charge of the professor of psychiatry at the All India Institute of Medical Sciences. We had a very big fundraising exercise where we had people like Kadragama coming in and helping us. And this is the Burala Centre. This is the residential facility in Gurakana by the Golgoda Lake. And these are some of the activities that are going on there. Basically, now I will come to the most important area. Major stakeholder professionals have a role to develop. That is you. Psychiatrists are considered as the major stakeholders, apart from the patients. They are the most powerful people. They are medical profession. The people will respond to them. There is a very big problem at the moment. Psychiatrists all feel that they are the most important people and they will have to decide on everything, which I don't agree with. mental health services, that is because that is not the reality. Mental health people or psychiatrists have certain skills which they have learned over the years, and they have to practice that. There are a lot of skills that they don't have, which other people have. So therefore, we must hand it over to them so that they can do their part of it. So mental health services will, the psychiatrists have a very experienced group of people. They have skills to treat people, individuals on a continuing basis. The assessment, diagnosis, various things like that. Then public health people have a skill to develop a network of services to provide them and manage and prevent, treat services in an identified population. Now, I know there's a very big fight that is going on in Sri Lanka at the moment. Psychiatrists say, no, we should be in charge of a district or a province or a division. Public health people say, no, we are in charge of it. I don't think that we should get into an argument of that nature. I feel that the health delivery system is in the hands of public health people. Mental health services will, by the clinical services, of course, they will interact. They will have a relationship. Then, of course, we have the other sectors like education, social welfare, justice, housing, employment, various other sectors, which have an influence on the mental health, promotion, prevention, and the treatment, especially the justice system, where we feel that, all of them still have a 1940s and 50s idea of the mental illnesses. The lawyers, the judge, everybody. We haven't educated them at all. We have appointed forensic psychiatrists, but certainly they do their work in the hospital. But these systems will go on as usual. If you really look at the special education section of the education ministry, if you look at the disability education in the education ministry, social services section, they are ancient. They are about 30, 40 years behind our times. Although there are people and there are programs, still very new ones, but somehow they are not integrated into the system. Then the government has to somehow come up with a plan where you have to integrate these kinds of things. We still haven't come to that stage. We still talk about the NIMH, National Institute of Mental Health. National Institute of Mental Health is an ancient institution, although Dr. Jan Mendis modernized and did very well. But what is necessary now, mental health services is essentially in the community, not community services at all. We are going beyond the community to involve the whole of the population, the whole of the life of the person, and whole of the family and the community and that kind of thing, for which we have to now be creatively thinking of a system. How does it work? Certain countries have come out with some solutions, but many countries haven't still grappled with that idea. That is where you come into play. I think Sri Lanka needs to have what we call the transformational leadership. The leadership is about setting the direction and motivating others to embrace it to achieve a common public goal. Leadership is something that we need to take them in a different direction. The aim is to transform the components of the present system. That means its aims, the values, the principles, literacy policies, mental health training, and so forth. Say, today, if you are going to have a clinical discussion, how does it revolve around? It revolves around a clinical diagnosis, reasons for the diagnosis, principles of treatment, and that's the end of it. But that's a very ancient 1940s and the 50s system. But today, the aim is essentially just to, at the end of all that, to find out whether the quality of life of that person has improved. If it has not improved, that means we haven't done a good job. Therefore, not only psychiatrists, all the stakeholders have to equip itself with capabilities necessary to understand and bring about a change, leading to improvement of mental health of people, families, communities. And these competencies include compassion, commitment, advocacy, accountability, social consciousness, innovativeness, and critical thinking. All these are issues that we just skirt around. We don't really think of. We think of only the substantive thing. What are the diagnostic criteria of schizophrenia or whatever it is? That's a minute, minuscule aspect of today's practicing mental health. So when I say that you will ask the question, now you are saying that, but when you go to the exam, that's what they ask us. Maybe true, but the exams also will have to change. We have changed over the years. No one is constant. We have to keep on changing. That is the whole idea of this discussion. When I asked Gihan, now I can talk only that aspect of it, but most of this will not interest the trainees. Their aim is to pass the exam. He said, no, let's talk about these things. Some of these people might get interested in it. And I think he's right. He's true. Now, some of these things that we are talking about today, I have heard while I was a trainee, but I didn't take seriously at all. I was very cynical about things. I said, they are talking all nonsense. This is all grandeur kind of thing. But today I realize that they are important to everybody. Now, this is a very important slide that we have to recognize. Increasing importance of what we call the transformative leadership. Learning and change. These are three words: leadership, learning, and change. Professional education is aimed at equipping the future doctors. Now we are talking about the doctors. You're sitting the exam this year, September. You want to be a psychiatrist maybe another 2 years or 3 years time, and you'll be, going to be height of your career in the 2030s, 2035, 2040, or whatever the time. And then that is a different world that you are in, the 21st century. You can't work in the 21st century with the 20th century ideas. And that's what we are doing. We are struggling to do that. We can't do that. So we are trying to equip you so that you can think along those lines to prepare yourself for the 21st century. And for that, you need the transformative learning. That is, the learning is not by gathering information, reading a textbook, finding out what are the guidelines, what are the criteria, what are the principal streams, but that is, rote learning. But we have to be really creative and thinking and integrate the outside that's going on outside so that we come out with a new way of thinking, what are called enlightened change agents. In contrast to informative learning, where you produce experts. Informative learning is essentially you give 10 points in the book, you remember all 10 points and vomit out at the 10 points at the court. We go to the court, they'll ask you, why are you saying that, doctor, this person is mentally ill? You will say, these are the reasons. And if there was a smart judge, if he asks a question, you will not be able to answer because you haven't really thought through the process. So therefore, we talked about the transformational thinking or learning or change to bring about, transform the way we look at the world. And already there is information that is available on one side. Already the people are wanting. I mean, today when I see patients, still I see some patients occasionally when I have a little time, especially my older patients, they will ask questions which will get me thinking. Now, you might not have that opportunity because you will not have time to be thinking. You will be spending 1 minute, 2 minutes, or 3 minutes, or 5 minutes maximum with the patient, probably giving the same medicines that your consultant has recommended. But when you talk about other issues, wide issues, if you have time, if you're interested in the person, you realize there are lots of questions that are coming up for which you have no answers because you have not thought about it, and no one has taught you, or you have not learned, and you have not been able to be responsive to that. But on the other hand, if professionals care about suffering of people, which I'm sure you are interested in, and health of the nation, they are accountable to the public. Public has to be given an answer. It is essential that the professionals use their position to promote mental health through transformative leadership. So what it means to me today is that you are going to be the leaders as psychiatrists and to bring about the way they think in the legal profession, in the educational profession, in the social welfare, in urban development, for instance. Now, all these things will influence your patients, going to be patients, and maybe the ordinary people who are living, that 80% of the people I talked to you about earlier, essentially to enhance their mental well-being so that they have a better achievement in life. And this is what's happening everywhere in the world. And compare that with what are called, what is called the informative learning, where you learn the textbook, where you learn everything that is going on in Australia, some hospital that you have worked in, and you come here and you try to introduce the same thing, which is not going to work. So please remember, you have to learn the basic principles, interpret them to the culture that you are working on, and then address the issues of the patients. What are their problems? And address the problem-solving approach to come up with a new solution to them. That is what your task is going to be. So just only 3 slides. There have been people like this earlier. I'm going to show you the place that I'm in Diatala in Happy Valley in 1890. The person who started this settlement, man called Samuel Langdon, who was the principal of Richmond College, Gaul. He was a Methodist priest who came from England. He felt very, very distressed about the poverty or impoverishment in the Ua area, Lower Ua Valley. After he retired from, he left the school, Richmond College, he came here and started a children's home. This is the first children's home in Sri Lanka in 1890 for the community. And this was the whole picture. And this is where we are living at the moment, actually. That's all. That building is just beyond our house. It's called the Holiday Bungalow now. He started a hospital. He started a reformatory. He started the orphanage for these children. He went around the entire Ua province and looked at the people who are impoverished. And he started the child movement in Sri Lanka. It's a very interesting second phase of 1937. This great man called Dr. S.T. Gunasekara, he was the first Director General Health Services at that time. The title was different. He was a principal of the medical school and also principal civil medical officer. He was very concerned about the mental insanity at the time. And he went on a Rockefeller Foundation. He met this gentleman called Edward Mepota. He was a professor of psychiatry at the University of London. He got friendly and he came back, and he had W.A. De Silva. He was the Minister of Health at the time in the State Council. They looked at Angoda and they completely transformed that. They produced a report called Maputa Report, which led to the establishment of a mental hospital and then the general hospitals and various things since then beginning. Then we had the next stage was this man, W.G. Wickramasinghe, in the 1965, he produced the mental health service in Ceylon at the time with M.D. Jayawardena, who was the Minister of Health. He transformed, he's the first person who promoted the establishment of the unit in Kandy, which Dr. Angelo Rodrigo went in in July, 1st of July in 1966. And this W.G. Wickramasinghe's report helped it. And then Arulampulam went to Jaffna, and then Channa Vijayasinghe came to Colombo about 1968, around that time, 68, 67, and established the unit in 1970. So they are great people. They are people who are really transformed the thinking and developed new areas. We had other people. We had Jaya Jayawardena. We had various other people who helped to establish Sahania. Again, transformed completely. I mean, these are all great people. A.T.S. Paul here, he was a great thoracic surgeon. E.A.G. De Silva, present day Ramesh De Silva's father, and Dr. Anthony's, they're all general people. We brought in people from outside to help mental health to go up. So they transformed kind of thinking. If you listen to Jaya Jayawardena's speeches at the time on mental health, you'll be amazed. It's even true today. We were able to get this lady involved, Chandrika Kumaratunga. She signed the document with memorandum of understanding with the WHO and got a lot of funds. Colombo South Hospital Psychiatric Unit came with her funds. Child Development Authority, various other psychosocial things came up during the periods of time. And also Nimal Siripala De Silva was very helpful. There was a great problem in the 1990s. We had only 17 to 18 psychiatrists. Then we brought in the concept of MOMH. That was very good. Then Nimal Siripala's idea was essentially we will train people for a short period of time called diploma in psychiatry for 1 year, because we had to send these people to the community. But the psychiatrists objected. Psychiatrist says, no, we need people with 5 years training. He said, right, we will send them to NIMHANS in Bangalore and train them for 1 year and come. Then you can forget about us. We will send them. Then the college or the board of study got a little bit uncomfortable. They accepted it. But I know even today there's a fight between psychiatrists and the general college of psychiatrists or the board of study or the whatever the people. And then we had the very interesting first meeting in 2001, SARC meeting. SARC countries, which we established. That was the beginning of the re-emergence of psychiatric services in Sri Lanka. And this is the plug that I was telling you about, which is in the Independence Arcade, which I wrote, which is still there. They were able to have the connection between the present day and the past. And this is a view of from our house, from the balcony in the evening. So as John Kennedy said, we must stop and thank the people who make a difference in our lives. And I'm sure over the years, many people have made an impact on our lives, and we are very grateful to you. And I am thankful to Gihan and the rest of the people who gave me the opportunity to share some of these ideas with you. And I hope this will get you to think a little bit. That's all that I have. I haven't given any new knowledge. I want you to think about the way the psychiatry has been moving and will have to move in the coming time. Thank you very much. How do we do this now?
Thank you very much, sir. That was.
Can you hear me? Can you hear me?
Yeah, we can hear you.
Yeah. Okay.
Thank you very much, sir, for that very, very thought-provoking and stimulating and eye-opening presentation. I think it's not only opened the eyes to the trainees about the history of psychiatry, but it made us think about the future of psychiatry. I think not only the trainees, I think, benefited from this. Yeah. Quite a lot of eminent senior psychiatrists also have joined in today, like Dr. Lalin Fernando, Dr. Neil Fernando, Dr. Swarna Wijayatunga, and so many others. And I'm sure they will also join in the discussion about the future of psychiatry of Sri Lanka and how we should develop our services. I think two comments made by you really are very important, inspiring, and the first one, that psychiatrists are not the leaders in the field of mental health, and we should incorporate others. I think that's a very important statement that we should all be very mindful about. And I think the Ministry of Health wants to introduce clinical psychologists to the government sector, and unfortunately there were some psychiatrists who opposed this. And I think which is a very important thing, that we incorporate psychologists also to our field. And the other very important thing that you mentioned about the community physicians, and some of us not liking the community physicians taking a role in the improvement of community psychiatry. Also, it's I think it's maybe one major fact which was the obstacle in getting the Mental Health Act or the mental health policy passed in Sri Lanka. So I think that's you made us aware of the holistic approach and how to think in a very wide holistic manner. I'm sure Dr. Lalin Fernando, Dr. Neil Fernando, Dr. Swarna Wijayatunga, and so many others would like to join in and give your comments. Sir, Dr. Lalin Fernando.
I mean, I'm so happy to hear those three names, because they were great people who have really done a considerable amount of work over the years. And they are also good individuals in the sense now, Dr. Lalin Fernando, I mean, even recently he spoke to me on the telephone. They are good human beings. So essentially what you need is your professional competence on one side, the humanity on the other side. I mean, ultimately we are helping somebody to overcome a problem. I mean, that's what it is. So in any group of people, there will be a range of, people. So at least what we have to do is to get the people who have a potential and give an opportunity for them to develop as much as possible. Now, I would not have come to this position if not for the help of the other people. I remember in the 1980s when I went to a meeting in Delhi, Dr. Bennett Jayavira, who was in Kandy, he asked me the question, why are you wasting time in Colombo? Go and learn something. And he's the one who really arranged me to go and have a fellowship at Harvard Medical School, which really opened my horizon. So similarly, all of us are trying to help us. Ultimately, this is not my thing or your thing or somebody else's thing. This is to share and give something better to the people. I'm sure the names of people you mentioned and also many others, names who were not mentioned, have been contributing. So let's try to develop that group of people. I'm sure there are many more to come in the present number of psychiatrists who are around, and then also the people who are waiting to join us. So
yeah, and I'm sure that there are so many people who have worked with you. I haven't had the privilege of working with you at Sahane, but I think there are so many people, so many of us psychiatrists who have been working with you at Sahane, and they would also like to comment.
Yes. Yes.
I think
Sir,
even
Lalin,
yeah,
yes.
can I?
Yeah, Lalin, yes, go ahead. Nice to hear your voice. Yes.
Thank you, Gihan, for this wonderful lecture. Now, if all of us who followed that talk, I would say, sir, the first slide was cloudy and misty, and there were a lot of unanswered things in that slide. But the last slide, the same view, showed us that you have enlightened us. So that was my experience since 1980 with you, sir.
Thank you.
As a medical student, we were wondering what these things are that you were talking, and then went on and on being a junior trainee or a senior trainee or whatever the designation. Always it was really enlightenment. So I see the next phase. Thank you, sir, for your zeal and passion for psychiatry, which is, I hope, will
Can't hear, no?
hello. Yeah, we can.
I can hear you, sir. Yeah.
Yeah, I can hear you, sir, but I think something happened to Dr. Lalin.
Yeah.
Dr. Lalin Sandu, can you hear us, sir?
Yes, yeah.
Yeah.
Sorry, Gihan, another call came and it got upset, sir. Yeah. So now, I will hand over the key to the next generation. Now, to be fair by psychiatry, sir. Now we are so fortunate that the next generation have taken over in a different scale. Now I'm seeing it happening in various parts of Sri Lanka where the juniors have taken over, and I must confess that I have done very little compared to what my trainees are doing now in the periphery, which is so wonderful and very happy to hear, sir. So at least we have tried our best to disseminate some of the learning which we have learned from great people like you and the rest of the teachers who were in our terms, in your terms, so it was more formative psychiatrists that we were, but now we are seeing transformative psychiatrists emerging, which is a good sign, sir.
That's very good.
Gihan, can I come in? I am Dr. Neil Fernando.
Yes, sir. Yes, sir.
Fernando.
Please do. Yeah.
Yeah. Yeah. Sir, thank you very much for your very informative, as your lectures are always, and also thought-provoking. And I would like to actually take this opportunity to specially thank you for two important things that you have done with regard to psychiatry, which I feel is very important. One is, of course, getting the psychiatry subject into the final year subjects. Earlier we had only 4 subjects. Psychiatry was added primarily because of your effort, and I think now all the universities are following that, and I see that that has actually improved the general knowledge about psychiatry in all doctors. When we passed out as doctors, our ability to do a mental state examination was minimal, because psychiatry was just there was only one question in the medicine paper, and you can even pass the medicine paper without even answering that question. That was the time when I passed out as a medical student. We were more experts in doing rectal examinations than mental state examinations at that time. But now the doctors have actually quite different. They are more talented and more geared because of this appointment of the final year appointment of psychiatry, thanks to your effort. And the second thing is actually what you mentioned in your speech about this starting this MO mental health program. And I was also very happy to be associated with you in training the first batch. I think if you can remember, in 2000, Dr. Munasinghe was also involved. 14 doctors passed out or were trained as MO mental health. And there was a lot of resistance, as you said, from our own ranks. But I think we have to say that the MO mental health was a group of doctors who actually took the mental health services from a tertiary level to the secondary level, and also to some extent to the primary level. So I think these are all very good initiatives which were pioneered because of your effort. So I just wanted to thank you, sir, for all the things that you have done, contributed, and still contributing to our service. Thank you, sir.
Thank you.
Thank you, sir, Dr. Neil Fernando, and also Dr. Larin Fernando, for your very valuable comments. Anybody else wanting to make any comments, or any trainees who want to ask any questions from Professor Nalaka Mendis, because this is a golden opportunity for you to ask your burning questions. Sir, so many trainees have asked whether is it possible to get your slide presentation. Is it possible for, if you want to, if you would like to share it with me, so that I can send it to all the trainees?
I can send it to you. I can send it to you. Yes.
Yeah. So if you can email it to me, I can.
I will do that. I will email it to you. Yes.
Yeah. Thank you very much.
I'll do that.
And I think we have recorded your presentation.
Mm-hmm.
Is it all right if you give your consent? Is it all right, because we have a Facebook page where we have an YouTube also, whether we can share your presentation with a group of people?
Yes. I mean, this is for a public good. It's not a personal thing. As long as people benefit from it, that's I have no problem. I will be happy, actually. Yeah.
Thank you. Thanks. And yes, I was very interested in that slide about the conference that you organized in 2002. I can remember Professor Kendall, and we were so eager to listen to him.
Yeah, Bob Kendall, big name, yes, very big.
Yeah, it was a big name, and he was the principal author of that big book, Comprehensive Psychiatry.
Yes, Bob Kendall.
Companion to Psychiatric Studies, I think. Yes, yeah, that was his book. And we used to read that book as trainees, and we were so eager to listen to him. And at that time, you invited Professor Andrew Sims and also the president of the Royal College of Psychiatrists, Mike Shooter.
Mike Shooter.
Yeah. And it was very interesting to listen to him. And he not confessed, but he admitted that he's suffering from bipolar affective disorder.
Yes, absolutely.
Yeah.
Yes.
So it was very interesting. I think it was one of the most interesting conferences that we ever had in Sri Lanka, with all those so eminent people from the world, all over the world participating. It was a very rich conference.
Yes, if I can I make a comment on that, Gihan?
Yes, sir. Yeah.
No, it was essentially an event of, contributions by a large number of people, very junior people and very senior people, and patients, politicians, administrators, bureaucrats, various other people, because we wanted to get them together. And in fact, the same comment was made by Bob Kendall after he went there. He went back to England. He sent a letter to me saying, this is the most interesting meeting I have ever been to, because you have assembled a range of variety of people, not only psychiatrists, and just to get the message across to the people. And unfortunately, he died a month later of brain cancer. But it's very important to talk about these things, and also do even much better, as Neil said earlier, or Lalin, both of them said earlier. There are a large number of people with great potential now than even before. So we can move on towards something more favorable, more desirable, and more positive in Sri Lanka in mental health. As long as we involve as many people as possible and get the resources together and improve our communications and improve the output of what we are doing, essentially, so that it becomes integrated into the system. Say mental health today, now if you really listen to a Western politician, he will talk very, very, very often about mental health issues. Now, he doesn't talk about schizophrenia or mood disorder. He occasionally does, but he also talks about the wider mental health issues in the world. So that is what our psychiatrists will have to get that message across to people, that you don't have to get frightened about it. It is not stigma. It is all of us have these kinds of problems, and we can come over that. That is the message I think we have to get across. I have finished, Gihan.
Yeah, okay. So then shall we wind up then for the day?
Yes.
Yeah.
And thank you very much. Thank you very much for inviting me and sharing your thoughts and things like that. I really enjoyed, and I will send you the slides to you.
Yeah. I think I should be the person who should be thanking you, not you, because on behalf of the Sri Lanka College of Psychiatrists, let me take this opportunity to express our sincere gratitude to Professor Nalakamendis for sharing his wisdom and knowledge and the vast experience with us, and also taking us down the memory lane of the history of psychiatry in Sri Lanka, and also giving the vision for the field of psychiatry in the future for Sri Lanka. And I think I'm very much hopeful that the trainees would have grasped the sense of your lecture or presentation, and that it will make them look at mental health in a more holistic, in a wider manner. And thank you very much, sir, for taking your valuable time and spending your Saturday morning with us and sharing your knowledge and the experience, and then educating us on this very important matter. Thank you very much, sir. Thanks a lot.
It was my pleasure, great pleasure, Gihan. All the very best. Thank you.
Thank you.